Okay, all set.
Great. Well, welcome everyone. I'm excited to have Dr. Ankur Doshi here today to chat with us about some of the fantastic work he's been doing. So Dr. Doshi is an associate professor of emergency medicine at the University of Pittsburgh School of Medicine and director of the University of Pittsburgh Medical Center Post-Cardiac Arrest Service, which is very unique and what we'll hear a lot more about today. It's a world-renowned clinical service focused on both resuscitation and the aftercare of cardiac arrest patients. Dr. Doshi is one of the co-directors of the University of Pittsburgh Center for Cardiac Arrest Survival, which is a single center focused on community and academic partnerships to combat disparities and inequalities in the chain of survival. For the past 20 years, Dr. Doshi has been a clinician, educator, and researcher in the fields of emergency medicine and cardiac arrest. He's cared for thousands of cardiac arrest patients at UPMC as well as other institutions. He's authored or co-authored more than 30 peer-reviewed publications in the field of cardiac arrest care and has lectured nationally and internationally on the subject. Additionally, he's an accomplished educator and mentor for undergraduate students, medical students, and graduate medical trainees. For these efforts, Dr. Doshi has been awarded multiple teaching awards, and we're so privileged and excited to hear from him today. So Ankur, whenever you're ready, take it away.
Thanks, Alex, for a really nice introduction. Thanks all for coming. I'm going to share my screen real quick in a sec. Okay, it's going to work. I just wanted to introduce myself, and most importantly, to just let everyone know this is actually not my work. This is the work of a ton of us here at Pitt and UPMC who've been working on cardiac arrest for, some of us 30 plus years. I have a short presentation to talk about some of the lessons we've learned about survivorship here at UPMC and Pitt. But more importantly, I wanted to hear after that from everybody else and your thoughts and your experiences, either in your roles as survivors or advocates or researchers or however else you're interested in cardiac arrest. So I'm pretty informal. And so I'll share some screens, and if folks have questions, just shout them out. It's way easier than anything else, because obviously once I share, I won't be able to see anybody, because welcome to the Zoom world, right? So let me do that. Let's just move along. Y'all can see this screen here? It's like blue and stuff. Cool.
Yep.
All right. So again, I am lucky enough to have worked at Pitt for about 20 years, give or take, intermittently. And I've done cardiac arrest work for about the same, either here and somewhere else. And we have, as Alex said, a post-cardiac arrest service at the University of Pittsburgh Medical Center, which cares for about 400 cardiac arrest to 450 cardiac arrest patients a year. Of course, many of those are inpatient in the ICU. And as we all know, the mortality and morbidity of this disease is high. And we see over 100 patients go home a year, which is probably one of the highest numbers in the country. And that started in 2007. And then in 2019, we developed a center at the University of Pittsburgh, really to work on the rest of the chain of survival. And just kind of disclosures, these are kind of where my grant support is. I am a co-PI on a number of NIH-funded studies as well. And unfortunately, none of these pay me. And Mary, if you want to pay me as a board of director for the Sun Cardiac Arrest Foundation, my kids would appreciate it, but I don't think it's going to happen. And just to remember, it's all about survivorship, right? We are in the business of having people go home and be who they were before their event. And one of the things we like to do is take photos of our survivors. And to show it to people like paramedics, and to show it to people like emergency physicians, ICU physicians, who don't always get a chance to see the great outcomes that they have been involved in taking care of. And what I really want to talk about today is this kind of under-researched part of cardiac arrest care, which is recovery. I think all of you probably know that this is probably the most important part of what we do. And how our patients and our survivors do is their recovery process, which lasts years and years. But it's really probably one of the most under-researched parts of the chain of survival. I give this talk to internists and stuff, and I have these statements that the sequelae involving after post-cardiac arrest after the survivorship are definable, predictable, and independent of etiology. And we know this from lots of just work that we've done with folks, and it's been published by partners of mine like Kelly Sawyer in a really nice AHA survivor statement. And then there's folks like Alex, who gave the intro here, who is proving that these sequelae are modifiable, right? Because you can identify stuff, but if you can't do anything about it, then it's not really as helpful for folks. But, you know, folks like Alex and others are really proving it's modifiable. And I think what I have been able to learn about over the last 20 years is not only that this is all true, but like, how do you actually operationalize it? How do you take a health center and know that these things are happening and make patients better? So that's what I'd like to talk about for the next, 15 minutes or so before we would open up to questions. I'm assuming all of you have seen the AHA survivorship statement and knows that, and I'm assuming many of you are survivors. Is that right? When I use statements like that, does that make sense to folks, or are folks confused when I say that? Joe's raising his hand.
I was going to say, I think it's mixed in terms of familiarity with Kelly's statement. So if you want to give just a one-liner on that. And then I do think most of us here, most of the folks on the call are survivors, but there's diversity in that as well.
Okay, so Kelly Sawyer wrote a very nice AHA survivor statement up in 2020, which really defined the domains that folks go through survivorship, and defined it nicely, not only with domains, but kind of a nice time course. If anyone hasn't read that, I highly recommend it. If you're a survivor, it may be a little triggering, actually. It's very truthful. And most people who are survivors who read it really kind of find a lot of resonance with it. And some people are ready to have that resonance and some people aren't. So I recommend looking at it if you haven't, but being in a really good mental space when you do it. And the way Kelly has done it, I had actually started building this in a different job at the same time. And when I kind of think of how do I operationalize it, I think you have to lump things in buckets. Because if you don't lump things in buckets for clinicians, it's very hard for them to know what to do. If you just say fix a problem, people struggle with that. So what we did is we took that information, we lumped it into 5 domains that we find very commonly for our survivors and our co-survivors. And I think that those of you who are survivors will probably reflect upon this feeling fairly real. Functional domain, which sometimes we use the word physical domain. So these are the limitations, the physical limitations that people suffer after cardiac arrest. Cognitive, which I think is very common and I think fairly self-evidentiary to most people who are involved in this space, that there can be cognition, there can be thinking things that we know change over time. Spiritual, which I call spiritual or religious, or some type of concept of well-being and purpose that is really important to people after a life-changing medical event like this. And then psychiatric or mental health. And I think anyone who's worked either with patients in this field or as a survivor themselves knows the sequelae that can happen from that, and kind of how we talk about that in time course. And then we think there's this overarching social domain that kind of overlies all of that. And we're not going to go through like each of the domains, because I think, again, most people on this call probably either have worked with people or kind of have known what these are themselves. So I'm not going to define them again. But what I want to talk a little bit about is how we've approached taking care of our patients in each of these domains, both in the hospital and then post-hospitalization. So, functional and musculoskeletal domain. Again, I think pretty real to most people who suffered a cardiac arrest or know anyone who's had a cardiac arrest. That could be in the ICU for a number of weeks. You could have rib fractures or other injuries as sequelae of that cardiac arrest that limit people. And we know that this is really common. So we have a number of assessments that we do in the hospital for our patients, mostly starting post-ICU, but sometimes in the ICU as well as different as it comes up. As soon as our patients are available to start doing things like physical therapy and occupational therapy, whether they're in the ICU or not, or on the floor, we start those really aggressively with our patients, noting that the longer people go without those kind of services in the hospital, the more difficult their rehab is. We have multimodal pain control and plans that we have for all patients, expecting that they have rib fractures or rib contusions from their CPR or other chest pain from defibrillations, etc. A lot of our patients get defibrillators and they may have pain and limitations from that. We have a whole plan on discussion with that. And the other thing that we found that was lacking in our system until we do it was an immediate consultation to our rehab specialist. So in hospitals, just because you get a physical therapy consult doesn't mean a rehab specialist sees you. That's not always a trigger. So we've changed our protocols here at Pitt that as soon as the patient gets a PT and OT eval, they get a physical medicine and rehab consultation. And that may be both physical and cognitive domains and other domains, but it's really, really important. Knowing that every single one of our patients needs an inpatient or outpatient rehab plan. That rehab plan could be quite simple if someone has a very short event and very low scores on their domains of injury, but everybody needs that. And the other thing we found is we're very aggressive trying to get our patients to cardiac and our pulmonary rehab. As many people probably know on this call, cardiac arrest is not a diagnosis that allows your insurance to pay for cardiac rehab. However, an acute coronary syndrome is, and so if their troponin is a little bit elevated as a definition of that, people can then go to cardiac rehab for that. We've made an association with our own cardiac rehab services here who are able to get a grant actually from a local foundation to help people who don't have insurance or are underinsured go through a cardiac rehab plan. And so we think that this is a very, very important thing that's very safety focused and really important to our patients. We actually wrote a little bit about this. We had a student kind of crunch and call all of our survivors, about 1,000 survivors total. And then he had about 100 ones that he really aggressively asked them about their rehab plans. And 2/3 of them responded. And not surprisingly to probably most of you, about 60% of those folks found that physical therapy was something they needed out of the hospital. 40% wanted cardiac or used cardiac rehab, and the same amount occupational therapy, only about 20% speech therapy, which was really interesting. Because we've had a number of our survivors say that speech therapy has been their most important thing they've actually used. And when they rate what the most beneficial is, it's kind of evenly split between cardiac rehab and physical therapy. And we thought that was a really interesting kind of finding. In terms of the cognitive space, again, I think this is fairly self-explanatory for most people on this call about what that is. We have started with very aggressive multimodal neurocognitive testing on each one of our patients. So every one of our patients, when they leave the ICU, gets multimodal neurocognitive testing. What do I mean by that? So neurocognitive testing is testing you would do to see if people have limitations in their cognition, and it needs to be very focused and very detailed. We found that you can't just ask people, how you doing? Because most people want to get out of the hospital. And if you ask them how they're doing, they're going to tell you anything they can tell you in order to get out of the hospital as fast as possible. No one wants to be in the hospital. And it's very difficult for patients with any cognitive sequela to identify their own cognitive sequela. Their families may identify and say, wait, whoa, my wife is not quite right yet. But that relies upon having that secondary person in the room, which we don't always get for our patients. So we have learned, and we do 3 tests as a minimum for all of our patients here at Presbyterian. We do the Montreal Cognitive Assessment, or the MoCA. Now, some of you may have heard that this is actually built for dementia screening, but we found that and wrote a paper that you can use this for cardiac arrest survivors as well, and has really fairly good reproducibility. And our rehab folks can use it because it identifies specific domains of injury, and we'll show the picture here in a second what those are, that they can tailor rehab plans to. What we've also found is that in other brain injuries, single testing is not appropriate because people can gain one test or one test they could just be bad at for whatever reason. So we do 3 different tests on everyone. We also do something called the CPCE, which was homegrown by our Department of Occupational Therapy, which is an extension of the traditional CPC, which was built in the 70s, which is just a 5-point scale on outcomes, you know, from dead to totally fine, which is not granular. This is a 9-domain test with multiple areas, and we do that test on everyone. And we do something we call the 41-cent test, where we ask our patients to manipulate coins, a quarter, a dime, a nickel, and a penny, and to do different mental calculations with that. We actually found that that's quite reproducible with our other testing. Of course, patients, again, get physical medicine rehabilitation assessments because they're the ones who work with cognition, inpatient and outpatient rehab. And we actually have a PhD, I don't know was here, I thought Kate was coming, she may be here, who wrote a couple papers about how physical rehabilitation helps cognition. And so we really try to push patients with any cognitive concerns to cardiac rehab. And we've built an assessment with association with our own physical medicine and rehab folks that all of our patients go to clinic as an outpatient if they need it, or go to an inpatient rehab. For those of you who don't know what these tests look like, the one on the left is the Montreal Cognitive Assessment, or the MoCA. You may have seen this yourself or done it yourself, where you draw some lines. It has multiple domains, including the top, which is executive functioning. The best way of describing executive functioning, I think, to laypersons is, what's it like to make a sandwich or to use an ATM? All those complex tasks that we do without thinking each other are assessed there. Things like naming and memory and attention, language and recall are all within this. And the really nice framework about this, our rehab colleagues know this really well. And so what they can do is take scores, take the patient's assessment on a test like this and extrapolate a rehab plan to it, to focus on what they need. Somebody has a question in the chat. Let me see what it is. Oh, Kate spoke last month. Okay. On the right there, we have our 41-cent test, which also has a really nice correlation with the executive functioning domain on the MoCA, and then the CPCE, and I know that's a little bit small, but if you see, it has 6 domains that we do in the hospital, and then 3 more domains, and 1 final domain we do actually after the hospital, and we do routinely on these patients. We also do follow all these patients by phone, and we'll talk about that later. All of our survivors get multiple contacts from us, and we'll talk about how we do that. And we continue to follow assessments in a repeated fashion to show that people are improving. The psychiatric or emotional domain, we know that many cardiac arrest survivors have mental health sequelae. We also think it's probably underreported in the literature because many patients and survivors who have the worst mental health sequelae don't answer their phone, don't answer questions later. And so we do on all of our patients depression and anxiety screening using standard testing that's done in the hospital for other things called a GAD-7 and a HADS, and we do standard substance abuse screening on all of our patients. We're here in Western Pennsylvania, and Western Pennsylvania and Appalachia has a very high incidence of the opioid epidemic. A number of our patients who are cardiac arrest survivors actually have opioid use as a predominant portion of the cause of their arrest, or at least a partial cause of their arrest. And we found if we don't do substance abuse screening, we are not doing appropriate secondary prevention. Just like somebody who had a ventricular arrhythmia and needs a defibrillator and doesn't get one and has a repeat event, that's a tragedy. The same tragedy occurs for folks who have used substances and had a cardiac arrest and then don't get appropriate detoxification or rehabilitation. Because if someone has another event a second time, it's really a tragedy that we could have prevented. So we do standardized substance use screening on all of our patients. We've made associations with our inpatient psychiatric services as well as some outpatient services. Outpatient psychiatric services are really one of the hardest things to come by right now in the country. And we, every time we meet a new case manager or social worker in the hospital, one of the things I always ask them is who's their best buddies who are therapists as an outpatient, and I keep a list of them and try to send our patients to anybody who has an opening. Because most patients don't need a psychiatrist, but they do need a therapist and someone to discuss it with. And as long as it's someone who has some idea of medical trauma, the sequelae of cardiac arrest are very similar to other medical trauma. The other thing we found is peer support is probably one of the most important things we do. So we offer peer support because we've had thousands of cardiac arrest patients and hundreds of survivors, we have a list of folks, and we try to have every survivor and co-survivor in our hospital who gets discharged matched with a peer. We have dozens of people on the list who are willing to do that, and have contacted people kind of all around the country by phone or Zoom just to say, hey, you know, we know a little bit about our own events. Your event may be similar. You know, how can we support you? We did write a really interesting abstract, which our student is finishing in a paper that showed that if we give our survivors and co-survivors the ability to get trained in CPR, it decreases their mental health sequelae. And folks who got a CPR kit to go home with, their mental health screenings improved at 6 months. And so we try to do this with all of our survivors, give them a CPR to go home kit called the CPR Anytime Kit, which comes from the AHA, and really kind of ask people to use it, to learn, to give it to their neighbors, to give it to their friends and their family, and hoping that that can help some of our mental health sequelae on people, for our survivors. The spiritual domain is one I'm really interested in, and it's really hard to define. But I think for anyone who's a survivor or knows survivors will know that people have had a really long change of life. And that change in their life manifests in all sorts of different ways. We've had patients who did not have their cardiac, or did not live in Pittsburgh, but had their cardiac arrest here, move to Pittsburgh later. Just because they've said, the only people we know are doctors in Pittsburgh, but it just kind of feels like our place now. And they've moved to this city. We've had people propose to their new spouse. We've had people, you know, unfortunately divorce their spouse. We've had all sorts of different sequelae, and we know that this is a real thing. So we really try to have all of our survivors in the hospital talk to a peer. We offer a pastoral care support. We have one chaplain who's actually doesn't work at our hospital, but works at the neighboring hospital, who's very interested, and so she's willing to speak to any of our survivors, and we refer her there as needed, and we refer folks to support networks such as this one, which I think can be really helpful for that. And this final is this social and reintegration kind of domain, which is really just really kind of based on the milieu that someone lives in. Everybody's journey is a little bit different. Everyone's journey with what their goals and wishes and values are different. For some folks, it's getting back to work. For some people, it's not getting back to work. For some people, it's being with their families. For some people, it's the fact that they lost their insurance because they got admitted to the hospital and their spouse lost their job. And how do we kind of interact with that? So what we've started here is we were able to grant support from a grateful family, a case manager, half FTE, about third FTE, and that person actually talks to all of our patients with these expected things. How's insurance going? How are you going to get back to work? How are you going to get around? How are you going to get to your appointments? Who is your PCP? We're a regional referral center here at Pitt, and so we get people from hundreds of miles away. And the more rural you get in Western Pennsylvania, the fewer services you have. So how can we get you to rehab? You know, if you live 100 miles from the closest rehab to you. So that case manager kind of sees all of our patients to try to prophylax some of these things and hope that that helps. Just again, from that same paper that our student wrote, he asked about 50 patients which care coordination services they need at discharge. And it was really interesting how low they were. This was before we had our own case manager. So very few of our patients in a very big center with lots of cardiac arrest patients actually get these support services they need, which was really interesting to us, and was really the impetus for us to get this grant to get a case manager to really help folks. So how do you really operationalize this? I'm going to spend 2 more minutes and then I think I'll be done. We start all of our work from the moment the patient comes to the hospital. Our service sees the patients, normally are involved with before they get transferred. We see the patients in the emergency room. We follow them through the ICU. We follow them out of the ICU. We follow them via home when they get home, via phone when they get home. And in the ICU, one of our our co-survivors just started a peer support network. So she and others will come into the ICU and talk to patients' families while they're still in the ICU and critically ill, and give them support. And we found that this is really, really helpful for our co-survivors as they're working through their loved one's critical illness, because no one else really understands what that's like. And that was actually built by the co-survivor and our nursing staff independent of us. And we've kind of co-opted it and helped her kind of follow that up. In the ICU, we'll start things like physical therapy and occupational therapy. When we get to the floor out of the ICU, we do multiple screenings, including our mental health screenings, getting our psychiatrist addiction medicine folks involved, getting our rehab screenings and our cognitive screenings, and making sure everyone has a physical medicine and rehab consultation unless they have zero issues. Just before discharge, we again recheck all of those screenings as well, make sure we haven't missed anything if someone's been in the hospital. And then once they leave the hospital, we have things such as psychiatry follow-up. Alex has helped us with mindfulness training on our patients. We have CPR training that we try to do with all of our patients. When I had started this initially at a previous job, I used to just get people to get vouchers to go to a CPR course. We found that that didn't work because there would be a survivor and their family and 3 college students who were maybe really interested in the CPR course, or maybe were there because they had to, and it was emotionally really challenging for our families. So what we do is try to do individual tailored CPR courses or send them home and do their own CPR trainings, which we found is probably the most effective. We make sure that they get inpatient and outpatient rehabilitation, including cardiac rehab as needed. I keep putting cardiac and pulmonary rehab for those of you who are interested. They have different indications and they are the exact same thing. They go to the same place for it and they use the same people. So once you know what the indications are, we are able to take the patients, figure out an indication for them. If someone has COPD or asthma, gosh, and they leave the hospital, they suddenly have a pulmonary rehab, a billable diagnosis, even if that really didn't have anything to do with why they had their cardiac event. We can get them into pulmonary rehab. So we kind of keep both of those in our minds, making sure that most of our patients go to one of them. We have our case management and community support arm, and then we have our long-term assessment for mental health screening. And I'm going to talk about this here. I don't know if I actually have a slide on it, but we have a group of student workers. I do have a slide on it. So this is actually our flow. So our post-cardiac arrest service is our clinical service, does all the inpatient clinical assessments and referral to any clinicians that needed. In hospital, we actually have a team of student workers who are probably paid as low as I think I can legally pay somebody. And we've trained them because they're all really interested. They all want to go to med school and other things. And we've trained them in assessing patients' care management needs in the hospital and doing depression, anxiety, and cognitive screens on the phone. And they see all of our patients in the hospital, call all of our patients at 1 week, 1 month, 3 months, 6 months, and 12 months after discharge. They are supported by a case manager. So she's actually comes from the mental health world, but has a lot of information on how to get services. And then they call her and they say, hey, I'm talking to patient X. They need 1, 2, and 3, and then she can help them do that. And we found that's a very efficient way of doing that. We can actually train these students who are really highly motivated, but don't come with a real background in this. We spend a month or so training them on what they need to do, allow them to do it. And we found that that actually fits the budgets better than actually having a clinician do it. If the care manager needs anything that needs a clinician, she calls one of us. We have a clinician on 24/7 for our service, and then they take that call as well and provide any services as needed. And in red is our next big push is handoff to primary care providers. As again, many people probably know on this call who've had a cardiac arrest themselves or for a loved one, most primary care providers don't have a lot of data on cardiac arrest. They don't have large patient cohorts who have cardiac arrest as opposed to something like cancer or stroke or heart attack. So what we try to do is we're trying to work on providing a warm handoff ability to all of our for all of our patients to a PCP. And we actually have started working with a couple of our local family medicine clinics to see if they want to do that. And there are actually people within the city of Pittsburgh who are willing to take on every cardiac arrest patient if they want. It doesn't really work for all of our patients who, some of them can't come from really far away. But one of the really nice benefits of the pandemic or side effects of the pandemic is that telemedicine is now something that's quite robust. So our patients can actually see providers even locally. I can see our local providers even from fairly far away as long as they're within the state. Someone asked, are the students from Pitt? And most of them are, not all of them are. And are they from the public health track? Some are. It's really just kind of random. Some are public health interested students. Some are students who come from an OT or PT background. People just kind of get referred to us because we've had so many students over the years that they say, oh, I'm leaving, but hey, my friend would be really good at this. And they do it. So we find students from all sorts of different places. A couple other things we've done. We've built a toolkit that we hand to every one of our patients at discharge. I think this is like, I don't know, 14 or 16 pages or something like that. I've lost track. It keeps getting a little bit bigger and then I have to wean it down so it doesn't get unwieldy. But you can see the topics we talk about, which is what's it like to return home after cardiac arrest? What should I expect? When should I be concerned? Like, who should I talk to? Should I come to the emergency room? Should I not? Can my PCP handle this? Some information on an individual recovery plan. We actually have a place for everyone to put all their doctor's appointments, any medical devices that were given to them, such as a cardiac stent or a defibrillator or anything like that. And they can keep that all in one place. And then we specifically talk about these domains that we talked about kind of in fairly explicit detail with our patients so that they know what to expect when they go home. We also have a list of outpatient resources in the area that we can pre-populate for folks based on where they live. So if they live in Altoona, Pennsylvania, for instance, we can look up and know the providers who are in that region and write down some ideas for them to at least start, because it's really hard to navigate this when you go home on your own. We also have similar one-pagers that we do that we've now most recently translated into Spanish and are working in Arabic, I think, for the next one, which is kind of cool because I don't know what it's going to say. At least Spanish I can look at when the people translate it and make sure it's roughly right. Arabic's going to be interesting, and our real goal is every time we get a patient who speaks a different language is to make sure we translate at least one page for them. Here we have a number of patients who speak Arabic and a number of patients who speak Nepali. So those are our two next places we're translating it to. And we have this one pager. I'm happy to provide that to, I think Mary, I think it's on the CASA website, right?
I think the
No,
what to expect.
we don't have the Spanish version available yet, but we will.
Okay. Okay, I thought I sent it, but if I didn't, let me know and I'll send it.
Okay.
So kind of what we do, we found that you need to assess patients. You can't just let survivors make it out of the ICU and hope that they're going to be able to do it all on their own. You need to find out which of these domains that have been well mapped and are in the medical literature the patient has needs for. So we do those assessments. We have a very strong referral background, both for inpatient versus outpatient care. We have helped coordinate peer support, both for co-survivors and survivors, that we do routinely for all of our patients. And then we have this phone touch point follow-up, where we've used, again, students who are really well and highly trained and motivated to call folks with the backup of a case manager and then a clinician. And now our biggest next step is handoff to an existing PCP resource. So that way those folks know kind of what to expect for our patients so we can keep them as healthy and happy. And with that, again, this is a huge team. We have a lot of doctors and APPs. I'm just going to show a bunch of pictures because it's really important for all of those people like Renee over here, who I don't have a picture of. She is actually our case manager. I don't have a picture of all of our students because it always changes. And then we have PhD level folks who are researching this and helping collect our data for it. So it's a big team here. We're really blessed, lots of survivors, both locally and internationally, that we get to touch base with. And with that, I'm going to stop, and I think we'll have lots of time for questions.
Thank you so much, Ankur. We will turn off the recording now so that people can feel free to speak and ask questions.